Hi, Dr. Michael Workman, and today I'd like to spend a little bit of time talking about a topic that we get asked a lot of questions on, and those are drains. And drains are our friends in general. We use them a lot in both plastic and in general surgery, and the purpose of a drain basically is to help the body remove excess fluid. And so those surgeries where we tend to create a big wound or an irritated surface, such as a tummy tuck or a breast reconstruction, or oftentimes if we've got a flap or a procedure where we move a lot of tissue, oftentimes we will place a drain in. And drains basically will stay in anywhere from a day or two out to sometimes 3-4 weeks and beyond. And the drain not only removes excess fluid, but it can help kind of suck down or draw in the two of the tissue planes that may or may not have been created with the surgery. So what I've got here is an example of a fairly common drain, and as you can see, the drain consists of two parts. There's the actual business end, or the drain portion, and this is usually made of silastic rubber, and it has multiple holes in it. Sometimes these are round, sometimes they're rectangular. They come in all different shapes actually. And then typically the drain gets a little bit wider in diameter, and it connects onto another silastic tube. And this is hollow, and they vary in size and whatnot. And so this is kind of welded basically to the what I call the business end of the drain. And all of this connects to what we call a bulb suction. And this here is a typical JP bulb suction, and the only purpose of this is to maintain suction or pressure on the drain itself. And in addition to that, it has a canister which allows the amount of fluid that is removed to be calibrated and to be measured. And this drain happens to be what we call a Jackson Pratt. That's the name of it. And if you look at it, it's got a little band which allows us to attach it to clothing. And most drains will have two holes at the top of them. One is usually capped by a silastic cap, and the other hole attaches to the actual end of our drain. And so I'm going to take this here, and it usually pushes on quite easily. And so after the drain is inserted, in order to maintain pressure and to allow the drain to work, typically what we do is we remove the one cap, compress the drain with your hand, and then put the cap on. And then, assuming there are no leaks in the line, this will maintain suction. Well, clearly, because we have the holes in the drain here, it's not doing that. However, if I was to take a clamp and basically obstruct that, hopefully this will maintain pressure for us. So I'll go like that. Yeah, and here you can tell that the this JP bulb is not getting any larger, and it's maintaining suction. And so when a functioning drain is in the body and the business end here is underneath the tissue, this tells us that the drain is functioning. So the next thing I want to do is, I've got a little model here. I just want to show you what the drain looks like under the skin. Okay, here what I've done is kind of modeled what a drain would look like in place, and we've got the JP, the bulb suction here, and you can actually see where the drain itself has been sutured to the cardboard here. And so this is typically what we like to see. Now occasionally the drain, the white portion of the drain, can become dislodged or can move out a slight amount. And if that happens, what you'll see, if it starts getting out to about here, there's the first set of holes on the drains will become exposed, and when that happens, we lose our suction, and the drain is no longer functioning. So if it's just a small amount that has come out, it's all right normally to just put a little alcohol over that and just to put it back in. And oftentimes, just by doing that, that will allow the bulb, the Jackson Pratt, to actually maintain and to hold its suction. And so I think that in conclusion here, in terms of the drain, functioning from a mechanical point of view, it's not unusual to have a small portion of the white end of the drain to be exposed. And as you can see, there's a suture that normally keeps it from coming out all the way. Sometimes, if there's too much pressure on that, it can irritate the skin. And so by putting oftentimes 1% topical lidocaine, which you can get at the Walgreens or most pharmacies over the counter, by putting that on the suture, that'll oftentimes relieve some discomfort. I think the other important thing we haven't talked about is it's important to every 3-4 hours to strip the drain. And to do that, we anchor the drain where it attaches to the skin with one hand firmly, and then we take the other hand, squeeze it, and what this will do is it tends to milk any clot that's in the drain and will allow that red clot to move down into the reservoir. And a bit of red clot here is perfectly normal, but we like to keep it from obstructing or blocking that. So, especially initially when there's a lot of flow, I think it's important every 3-4 hours when one checks the drain to what we call strip it, but make sure that you're anchoring it so it doesn't come out or cause irritation on your on the actual skin there. The other thing is every 3 to 4 hours, it's important to measure and record the amount of drainage. So the way one does that is remove the top and then try and hold the drain flat, and if you look on the side, you'll see 25, 50, 75, 100. Those represent cc's. So typically, remove the top so that the drain expands, and then let's say we've got 50 cc's there. We would then mark that down on the drain sheet, which we've given you. Then turn it over and drain out the drainage into usually a styrofoam cup or any sort of cup, and then oftentimes just pour that down the toilet, which would be fine. At the completion of that, we want to always remember that we need to have that drain still applying that suction, and so squeeze it, just like a hand grenade, and take the top and put it in the middle. And like that. And it's probably going to squeeze now just because it's not a real drain. And the one last point I'd like to briefly go over is that initially we tend to see bloodier fluid, so it's oftentimes what we call sanguineous fluid coming from the wound. Usually over several days to weeks, that sanguine or red fluid will turn more to a serous color. Serous fluid tends to be the color of straw. So initially you're going to see red drainage, and sometimes it can be frank blood, but that will transition normally over the first 2 days to a week or two, depending upon where the drain is, into that sanguineous drain. It's important that you write down, especially initially, how much drainage you have, and it's important to inspect it to make sure that that bulb is maintaining pressure, because that's the function of the drain. So if you have any questions, call your physician in terms of the drain, but these are some of the basic questions that we see and some of the answers that hopefully will help you. So thank you very much.